Get started so we can hear you talk more, Roy. So everyone, welcome to the Brain Imaging Research Center Speaker Series at University of Connecticut. I am the organizer, Famika Haight, Director of BIRC and Professor of Psychological Sciences. We started the speaker series first in a hybrid format in 2018, pre-COVID, and now virtually. And we have hosted a number of really world-class senior and junior researchers, as you can see on the list here down below where it says past speakers. And we have all these people as recorded, most of these people's recordings on our website. So I encourage you to visit our website where you can see these, and also you can get on our speaker series by emailing birk@uconn.edu. So please do visit our website and also sign up to be on our listserv. Some housekeeping items: if you have questions, I know you all know the drill, but please enter in the chat box and we'll take it all at the end. And if you have something urgent to us, you can do it privately, or you can do it to everyone if you don't mind, if it's not confidential. And let's get started. Today, it is my greatest pleasure to introduce Professor Roy Hamilton from University of Pennsylvania. I've known him since he was a medical student. I think you did not have gray hair back then, if I'm not mistaken. But you were as intellectually curious, incisive, and articulate back then as well. I remember when you were at Harvard University when we just met, and when I first arrived from Japan. Another fun fact: Roy is half Japanese, and I vividly remember that because I just arrived from Japan back then, and it was still in the 20th century, so it was a long time ago. Let's see. So Professor Roy Hamilton has a bachelor's in psychology from Harvard University, an MD from Harvard University School of Medicine, and a master's degree in health sciences and technology from MIT. He completed his internship at UCLA and has been at UPenn since as a neurology resident, a fellow in cognitive neurology, and now as associate professor of neurology at UPenn with a secondary appointment in physical medicine and rehabilitation. He's also the director of Penn's Laboratory for Cognition and Neurostimulation, LCNS, and is also the director of the Penn Brain Science Translation, Innovation, and Modulation Center, and in short, BrainStim Center. That's a clever name. And the central thrust of his research is to use non-invasive electrical and magnetic brain stimulation to explore the characteristics and limits of functional plasticity in the intact and injured human brain. And in his spare time, he also serves as the Assistant Dean for Culture Affairs and Diversity at UPenn's Perelman School of Medicine, inaugural Vice Chair for Diversity and Inclusion for Penn, the Neurology Department, co-director of Penn Minority Scholars in Aging Research Program, and the Diversity Search Advisor for the Department of Neurology, and Associate Editor for Equity, Diversity, and Inclusion for the Journal of Neurology. Wow, we all thought we were busy, and just taking me a couple of minutes just to read off all his titles. Has also received numerous prestigious awards, and I won't go through all of them because it was like a page long, but just some of the highlights is the American Medical Association's Young Physicians Community Service Award in 2011, UPenn School of Medicine's Minority Faculty Hall of Fame inductee in 2013, Dr. Martin Luther King Jr.'s Community Involvement Recognition Award from UPenn in 2013, and the Norman Geschwind Prize in Behavioral Neurology from the American Academy of Neurology in 2014. He has published numerous papers, and we're looking forward to hearing a portion of it today. His resume is 49 pages long, but today we are thrilled to hear from you about the non-invasive brain stimulation technologies to characterize and enhance language processing in persons with aphasia. I'm really looking forward to hearing what you've done over the past 20 years since we last connected at Harvard. So please join me in welcoming Professor Roy Hamilton.
Well, thank you. That was such a wonderful and flattering introduction, and it is such a joy to reconnect. As Famika was saying, that it's we had known each other over 2 decades ago, and it's great to be able to reconnect and see what we're up to. And I am so grateful that you invited me to come speak. What we're going to talk about for the next approximately an hour is the work that we've been doing at the University of Pennsylvania and that others have been doing in the use of non-invasive brain stimulation technologies, magnetic and electrical brain stimulation technologies, in the characterization of language and in the treatment of individuals with aphasia. And I like to describe this talk as being one part historical, one part allegorical, and one part aspirational. And what I mean by that is we're going to review the history of the work that we had done. So it's going to be retrospective in some ways. And we're going to review that history through a somewhat oversimplified story about how the language system adapts in the setting of aphasia. So that's the allegory part. And then we'll close by talking about the directions that I think our lab and in some ways the field of neuromodulation for aphasia is going in. So I have no relevant financial conflicts or disclosures for this particular talk. And here is our roadmap. And we're going to start by talking about an idea that has motivated a lot of work in the use of non-invasive brain stimulation in language and aphasia in particular over the years, and that is interhemispheric interactions, in particular in non-fluent aphasias. Then we'll move to talk about transcranial magnetic stimulation for post-stroke aphasia, and then shift to discussing transcranial direct current stimulation or electrical stimulation for post-stroke aphasia, and then discuss that same technology, transcranial direct current stimulation for neurodegenerative aphasias, the so-called primary progressive aphasias. And then, as I said before, we'll close by talking about challenges and next steps for neuromodulation in this field. So I'm sure that many of you are familiar, at least to some degree, with the burden of suffering that is imposed by stroke. But for those of you who aren't intimately familiar with it, let me say that the global lifetime prevalence of stroke is about 1 in 6. So that's 1 in 6 persons. That is a very large number. And aphasia is the most common focal cognitive deficit associated with stroke. Depending on what papers you read, it may comprise approximately 20% to 40%. So let's split the difference and say about a third of people who present with a stroke will have some degree of acquired communication deficit because of that stroke. So what we're going to talk about, however, with respect to these individuals is what happens as they are recovering from their stroke. Now, the problem with aphasia is that many individuals will not recover fully, right? But most individuals will express over the course of days, weeks, months, some degree of improvement. Well, if the language system is being injured, if it's being damaged in the context of a stroke, how exactly is that happening? What areas of the brain or what mechanisms are individuals with post-stroke aphasia using in order to mediate that recovery? Well, first we could start by looking at what the difference in patterns of activation are. You know, how individuals who are healthy speakers differ from individuals with aphasia with respect to how they appear to be engaging the brain during the use of language, right, during language tasks. So stretching back now to the sort of beginnings of our work, which are before 2015. This is sort of from this image is from a 2015 recap of that and extension of it. But a number of years ago, Peter Turkeltaub, who was at that time a fellow in cognitive behavioral neurology at Penn, has since gone on to be a faculty member of his own at Georgetown and a physiologist, and also runs a brain stimulation laboratory. But at the time, what we first did was start by looking at how individuals with aphasia appear to activate the brain. If you perform a quantitative meta-analysis of studies in which individuals with aphasia were performing the same tasks as healthy speakers and healthy language users, how do those patterns of activation differ from the patterns of activation in healthy language users engaged in the same tasks? So that's what I'm showing here. And what you can see in the top is healthy language users, as I'm sure many of you anticipate, are engaging across a variety of tasks, a constellation of areas that are predominantly in the left hemisphere, right? Including areas that ought to be familiar to individuals who have some degree of knowledge of sort of normal language functions. There's no surprises there. But by contrast, individuals with stroke, and in this case, chronic aphasia, so 6 or more months out from their stroke and aphasia, appear to be activating a network of brain areas that involves both the left hemisphere and in particular areas that are sort of around areas that had been injured, or we sometimes refer to them as perilesional areas, as well as a constellation of areas in the right hemisphere, right? And many of those areas appear to be distributed in a way that's kind of the mirror image, or at least sort of on the other side of regions that in the left hemisphere healthy speakers would be engaging in order to perform language tasks. Well, this raises a series of questions about what is going on in that right hemisphere. And that's what we're going to talk about for the first, I don't know, 10, 15 minutes of this talk. So you could very simply break this down into a couple of fundamental ideas, a couple of fundamental hypotheses about what's happening in that right hemisphere when individuals with chronic aphasia are activating it in the context of language tasks. A somewhat intuitive notion would be that this area is compensatory, that it's doing something useful, and that's why it's engaged in these individuals with aphasia. It's part of their recovery process. There's also an alternative theory, and I have to say, one that motivated the field of non-invasive neuromodulation around aphasia treatments for some time. And that idea is that, in fact, that right hemisphere activity isn't helpful. It's not compensatory. It's spurious, and worst case scenario, deleterious, that it's harmful, gets in the way of language performance and language recovery in patients with aphasia. And we'll talk a little bit about how that hypothesis works in a second. Then you could imagine that the story is actually more complicated, right? That perhaps there are some compensatory elements or properties to this constellation of brain areas that's activated in the context of language in persons with aphasia, but that perhaps that system is not perfected, that there are inefficiencies or other ways in which that system could be more optimal. Of course, just to round out the full set of possibilities, I guess one possibility is that this activity is completely epiphenomenal, that it neither informs nor detracts from the performance of language tasks in patients in persons with aphasia who are trying to regain language use after having had a stroke. Okay. So let's talk a little bit about, well, at least the first 3 of these ideas, that it might be helpful, that it might be hurtful, or that it might be some combination of the 2. So where do we get the idea that the right hemisphere might be compensatory in nature? Well, there are a number of points of evidence and arguments that can be made about this. For the sake of our narrative, and I think because it's interesting, I like to point to what may be the first known example of potential compensatory change or compensatory engagement of the right hemisphere in language. And that's from a case from 1877. This is a case reported by a Dr. Thomas Barlow. And he was reporting on a child, a 10-year-old boy, who suffered from stroke as a result of infective endocarditis. In other words, he had infection in his heart, and the infection was sending infectious emboli up to his brain where they were causing strokes. And so, unfortunately, his first stroke rendered him unable to speak, or rendered him aphasic. So let me just put up how Dr. Barlow describes that patient's symptoms. Here are Dr. Barlow's words. He had lost his speech. He could only say, ha, ha. He could not grasp with the right hand, and he dragged the right leg when put on his feet. So pretty apparent for those of you who know a little bit of neurologic localization. He's got paresis of the right side of his body, and he's got a language problem. So, pretty clearly, he's got something going on the left hemisphere of his brain, right? Now, this boy being 10 years old, as children often do in the setting of neurologic injury, he made a pretty good recovery. So Barlow goes on to say, In 10 days, he was greatly improved. The speech had returned on the 10th day, but occasionally he made a mistake, gave the wrong name for a boy, and did not seem always quite to understand what was said to him. In a month's time, he seems to have quite recovered. Well, that was great for that child at that time. He seemed to show a pretty remarkable recovery. Unfortunately, what they did not have in 1877 was really great treatments for infective endocarditis. And so, unfortunately, this boy suffered from a second stroke. Here's how Barlow describes his symptoms after he suffered from his second stroke. The only approach he could make to a voluntary articulate sound was ah. He could cry vigorously. There was no lack of voice. From his admission, he appeared to understand all that was said to him. When asked his age, he counted 10 on the questioner's fingers, counted 4 when asked how many brothers he had, and so forth. He made signs for what he wanted, and the signs were correct. Unfortunately, this child went on to pass away, and he went to autopsy. And what Dr. Barlow found was that when he examined this child's brain, he did indeed have a stroke in the left hemisphere, in areas of the left hemisphere that one would associate with, one would now associate with language processing. But what also was the case for this child was that he also suffered from a newer right hemisphere stroke. And so the take-home point here is that this is an argument that the recovery that boy had initially shown after his his first left hemisphere stroke, right? That recovery may have been mediated, at least in part, by the right hemisphere, as evidenced by the idea that when he had a second right hemisphere stroke, that his aphasia returned. So, like I said, there are many other pieces of evidence from neurophysiology, other case studies and other converging forms of data that support this argument. But I thought that this would be a sort of a very concrete and sort of initial and historical way to illustrate this first point, that the right hemisphere may be compensatory in nature. Well, how about that other idea, that the right hemisphere is somehow harmful, that's deleterious? This idea derives from the notion of inhibitory interhemispheric connections. And so the way this idea works, the way this model works, is that the two hemispheres are richly connected, as I'm sure most of us know, through a large white matter pathway called the corpus callosum. Right? It turns out that if you interrogate those pathways, for example, you stimulate on one side, you measure on the other, that in many cases, those pathways running between the two hemispheres appear to have inhibitory effects, one hemisphere on the other. Okay? And so the idea that right hemisphere or the intact hemisphere activity might be deleterious comes from the notion that if you have a lesion of one hemisphere, one thing that might happen is that you have a decrease of inhibitory transcallosal input to the intact hemisphere, right? And so in that setting, the intact hemisphere may become disinhibited. It may become more excitable. However, that increased excitation wouldn't be a reflection of coherent or useful neural activity. Rather, it would be just a release from the inhibition on the basis of the damage on the other side. And furthermore, the way this model works, you could imagine that this hemisphere would then project its inhibitory inputs, now increased inhibitory inputs by virtue of this disinhibition of that side, its increased inhibitory inputs to the damaged side, right? Thus further suppressing a hemisphere that is already ostensibly suppressed by virtue of the damage that it has sustained. So according to that model, you could actually improve the activity of that damaged hemisphere either by taking steps to try and increase its activity, or maybe by tamping down the activity of the intact hemisphere. And you can demonstrate this that this holds some water. There's some evidence to support this, at least in motor physiology. So, for instance, if you look at individuals who've had a stroke and you stimulate over their motor cortex, you try to generate a motor response by stimulating over the motor cortex, what you find is that compared to individuals who are healthy, individuals who have had a stroke will have, of course, a decreased output from the damaged hemisphere, but also an increased output coming from the hemisphere that is intact. And that, as I was saying, that one way to try and even that out, if you will, is to either inhibit the intact hemisphere or try to excite the damaged hemisphere. So so that is the line of thinking that the model that supports this idea that the right hemisphere may in fact have some inhibitory or deleterious input with respect to language recovery, and that the right path to improving function might be to actually suppress that excessive activity. And I just want to show you an old imaging study. It's a little dated now, but it's reflective of the kind of thinking at the time when this was a sort of dominant notion in the literature of what people were doing. So this comes from a study in which individuals with chronic stroke were in the scanner performing a naming task, and what's being done here is that the investigator is doing subtractions of when the patients with aphasia are either naming these items correctly or incorrectly. And to skip to the bottom line, what they're demonstrating is that in the instances in which individuals are naming the items incorrectly, those were the instances in which there seemed to be increase in right hemisphere activity. And so the argument put forth by these investigators and several others around this time was that that increased activity was actually, if anything, adding noise or being patently unhelpful to the processing of the language task. So with that backdrop, I showed you the maps that Peter Turkeltaub had created previously in doing a what's called an activation likelihood estimate, or AL meta-analysis, a technique he actually invented, looking at comparing individuals who were healthy language users to individuals with chronic stroke and aphasia performing the same tasks. Well, we went one step further than that in our early days. And what we did was we asked ourselves two basic questions. Those basic questions were, well, first of all, is an area in the right hemisphere of a person with chronic post-stroke aphasia a homotope of an area in the left hemisphere of healthy language users? In other words, is it a sort of mirror image area, or pretty close to being a mirror image area of similar areas in the left hemisphere in individuals who are healthy language users? And then a second question we asked is whether the area appears to be homologous with respect to its patterns of activity. In other words, we looked at a variety of different language tasks, right, and comparing healthy speakers versus individuals with post-stroke aphasia. And if it was a case that, let's say we pick one area and that area was active at the same time that a homologous area or a homotopic area, the left hemisphere, was also active for those particular tasks, but not active for the set of tasks that a homotopic area was not active in the left hemisphere of a healthy language user, and so on and so forth, right? Well, that would suggest to us that that area was somehow engaged or somehow relevant to the performance of those tasks, as opposed to if the pattern of activation that we saw in some area was completely orthogonal to what we saw in the left hemisphere of a healthy language user. That would suggest that that area was not engaged in the same kinds of tasks as that region in the left hemisphere of a healthy language user. Well, it turns out that when you do that kind of simple evaluation, most of the regions that we identify as being engaged in the right hemisphere in persons with chronic aphasia were both homotopes and homologous in their patterns of activity. There was, however, one area that was conspicuously not homologous in its pattern of activity. It's that area right there. It's in the inferior frontal gyrus, in the pars triangularis, what would be a mirror image area of part of Broca's area, Brodmann's area 45. And we found that just relative to its mirror image neighbor in the left in individuals who are healthy language users, that area just wasn't homologous in terms of its patterns of response to different kinds of language tasks. All right, so now we've identified all sorts of different areas in the right hemisphere and characterized them a little bit, but we haven't really done anything to probe or manipulate at that time those regions to figure out if those relationships are really are valid. So that's where the first workhorse of our laboratory came in. So that's transcranial magnetic stimulation. And I'm pretty sure that I don't have to give a prolonged explanation of what TMS is to this group. So let me just give the thumbnail sketch version of it. So transcranial magnetic stimulation involves the use of a large winding of coil. You place it over the scalp, and then you pass an enormous amount of current through it. And when you do that, that creates a fluxing magnetic field. That fluxing magnetic field is capable of inducing sufficient current in underlying brain structures to depolarize them, right? To excite them to the point of stimulation. And relative to other technologies, it's pretty high resolution. Think a centimeter to a centimeter and a half on the surface of the cortex. So something about the size of your thumbnail and the surface of your cortex that you can hit pretty reliably. Depending on how you're applying it, it can be given in an excitatory or in an inhibitory way, depending on the pulses and patterns that you employ. It's very safe. It's the one risk that we sometimes talk about with respect to TMS, the possibility of inducing a seizure, which is very, very uncommon and really vanishingly uncommon in the context of well-published safety parameters. And when you apply TMS repeatedly, you can induce long-term changes in cortical excitability and long-term changes in behavior through neuroplastic processes that we think resemble known processes of neuroplasticity like long-term potentiation. So with that brief introduction to TMS, what we did was we brought individuals who were chronic and who had chronic non-fluent aphasia on the basis of having had a stroke. And we explored various areas. Remember, there's a constellation of areas in the right hemisphere that seem to be activated, seem to be engaged in the context of post-stroke aphasia. So we brought individuals in, and on the basis of that inhibitory interhemispheric hypothesis, we applied inhibitory stimulation to various spots in the right hemisphere that we thought might be engaged in these individuals, with the thought that if we were able to induce a language improvement, a transient language improvement on an individual basis in any one of those spots, and we were agnostic as to whether or not it was going to be the same spot across individuals. So different folks may have different best points of stimulation. If we could induce a temporary language change in those individuals, a language improvement, ideally, that we would bring those individuals in, and they would either be randomized to receive real transcranial magnetic stimulation or sham stimulation, followed by a 2-month follow-up and a 6-month follow-up. In our early work, we did not have the heart to make our individuals receiving sham stimulation follow-up wait 6 months out, and wanted everyone to get stimulation. So it was a partial crossover. Everyone eventually got stimulation. And again, we're applying 1 Hertz inhibitory TMS. And indeed, what we found in those early days was that we were able to induce improvements in performance of a variety of different language tasks. What I'm showing here is naming performance, so picture naming performance. I want to be clear, because I know if I don't say this, I'll get a question about it later, that because of the reason for which this figure was originally made, there's an important component that's missing from it, which is the sham arm. And I can tell you that it is a flat line, that individuals who receive sham did not receive any benefit with respect to their language performance in the naming task. We also did functional imaging on these individuals. One thing that we noticed right away is that while group level fMRI demonstrated, in our ALE analyses, demonstrated patterns, specific areas of common activation across individuals, that on an individual level, the patterns of activation were pretty different, were pretty heterogeneous. But the other important thing that we noticed, which I'll cycle back to in a second, is that applying inhibitory stimulation to these individuals did not necessarily result in a lasting suppression of right hemisphere activity in the context of language tasks. Instead, what we tended to see was shifts in patterns of activation in these individuals. And we were able to demonstrate that we could induce improvements in spontaneous elicited speech, So for instance, what I'm showing here is the number of items that individuals were able to generate in response to a prompt. The particular prompt was something called the cookie theft picture. And so, this is you can see the stimulus right above and you can see that there are many things that seem odd about the picture that subjects could talk about. And so we let them generate spontaneous speech in describing this picture, and found that individuals generated more nouns, more verbs, different classes of words, open and closed class words, more narrative words. Importantly, individuals weren't generating more of these words simply because they were speaking for a longer period of time, right? That would be a really mundane reason why they would have more word output. And it wasn't that they were speaking any faster. It's that when they were speaking, during their speech, they had fewer false starts and made less errors. And so that the efficiency of what they were saying was improved. Well, I told you this talk is one part historical. Time has gone by. And so, we are now certainly not the only individuals, only research group to have applied this TMS approach in patients with chronic non-fluent aphasia. And so a few years ago, we did a meta-analysis which demonstrated that indeed, TMS given in this way in individuals with chronic non-fluent aphasia has a consistent, reliable effect compared to the delivery of sham. Now, remember that a few minutes ago, I mentioned that the way we structured our early work was that we brought individuals in and we searched over different sites, and we took the site, whatever site was best for each individual subject, right? Whichever site elicited a brief change in naming performance or in language performance, that's the one we went for in our TMS trial of, I don't know if I mentioned, but the TMS we administered therapeutically was 10 days, 10 daily sessions of TMS. So it turns out that the site that was best for most individuals was the same site. It was this site in the green here. It's in the inferior pars triangularis. It's Brodmann's area 45. It's an area that would be a kind of mirror image of a region of Broca's area, except on the right. And if those descriptors sound familiar, it's because that's the same area that we identified in our meta-analysis as being an area that didn't seem to be homologous in its patterns of activity compared to its left hemisphere neighbor in healthy language users. And so our idea here was that perhaps by suppressing the activity or downward, inducing a downward modulation in the level of activity in this area that didn't seem to be acting in a sort of coherent homologous way, that we were suppressing a kind of noisy node and improving the efficiency of a bilateral network of language areas that were engaged for language tasks in these patients with aphasia. Now so our suspicion was that the right hemisphere wasn't actually all bad, so to speak. That it isn't the case that the right hemisphere has a singular role, and that singular role is to be disinhibited and to project inhibitory inputs to the left hemisphere. But this particular study doesn't really demonstrate that, right? It just suggests that the area in which we need to have modulation in order to induce some improvement was pretty focused and pretty conserved across our patients. However, we did have one case that really, in our opinion, made the point that the right hemisphere's role is not monolithic. So this is a case of one of the subjects in our study who did benefit. When we did the site finding phase, she benefited most from, at least temporarily, from inhibition of the pars triangularis on the right. And what I'm showing here is before and after fMRI data, and then a subtraction in the bottom line there, where you can see that that inhibitory 1 Hertz TMS of the inferior pars triangularis in that person resulted in a decrease in bold activity. So we're inhibiting where we want to inhibit. And when we followed her up, she did have some degree of improvement in her language ability. Unfortunately, this patient suffered from a second stroke. In some ways, kind of like our case of the boy that Thomas Barlow reported on. So what I'm showing you here in the top of the slide is obviously the evidence of her prior stroke. That's the sort of large left hemisphere. Now things are inverted here, so left is on the right. Large left hemisphere lesion. You can also see a representation of where we ended up stimulating. But on the bottom, under B there, what you see is the diffusion weighted images of this patient after she suffered from her second stroke, which is a subcortical stroke, so white matter primarily affected on the right hemisphere. Now, if you were a strict adherent to the interhemispheric inhibition hypothesis, interhemispheric inhibition hardliner, you would say, well, maybe it isn't in general, it's not a good thing to have a right hemisphere stroke, but maybe in this particular patient, since you already demonstrated that she seems to respond to inhibition of the right hemisphere with TMS, maybe having a lesion in the right hemisphere would further decrease that inhibitory transcallosal input to the left hemisphere, and ironically somehow be a good thing, or at least not a bad thing for this patient with respect to their language recovery. Well, that was just not true. So what I'm demonstrating here is that when this patient very graciously let us test her afterwards, what we found was, in fact, she very specifically had a substantive decrement of her language ability after that subcortical right hemisphere stroke, a sort of latter-day tale similar to Barlow's patient. That right hemisphere lesion really seemed to impair her language ability, even though the same patient seemed to experience a benefit when we applied focal inhibition at a particular site. Right? And so we interpreted that as further evidence that the right hemisphere's role in this bilateral network of regions isn't monolithic, that in many ways it seems to be helpful, it seems to be compensatory, even in cases where inhibition at a specific site seems to also be helpful. Now, one caveat is that a lot of what I've said so far may apply primarily to individuals with more anterior and anterior lesions and non-fluent aphasia. So here's some data from Dorothy Sauer's group in Germany, and sort of outstanding researchers in aphasia. What they are known to do, amongst many other things, is serially image individuals with stroke and aphasia, and evaluate the patterns of brain activity that can be seen in those individuals. And so what this figure shows is that there are different patterns of activity with respect to homologous brain regions and homotopic brain regions, depending on whether your lesion is more anterior or more posterior. So just to direct your attention to the bottom half of the slide, for individuals whose lesions are more anterior, it does seem to be the case that that areas that are mirror image areas, sort of right lesion, well, they call them homolog cortex, but sort of homotopic areas, that they do seem to come online relatively early in these individuals and stay active, stay engaged during language tasks in these individuals through the chronic phase of stroke recovery. Whereas it seems that these areas don't really get engaged in individuals with more posterior lesions, or at least not to the same degree. You can see in the top graph that the green line, which represents the mirror image areas, is sort of at the bottom of the slide throughout the different time phases. And so that's a caveat, because much of what we've done has been in patients with chronic non-fluent aphasia as a result of anterior lesions. So just to give an interim summary on the right hemisphere's role in recovery, or to put this in a slightly more tongue-in-cheek way, the first 5 years of my work summarized in 4 words. We can think about those 4 different ways in which the right hemisphere might be involved. I'm just going to first take off the table the idea that it does nothing. All right. However, it can't simply be beneficial in the sense that if that were the case, well, then applying inhibitory TMS to any site wouldn't be especially useful, right? And so, we think it can't be just that. On the other hand, it certainly can't be all deleterious. It can't all be harmful, or else we wouldn't anticipate that lesions of the right hemisphere would then specifically and focally have a deleterious effect on individuals who are trying to recover from aphasia. So, we think that we're talking about a much more sort of nuanced constellation of brain areas involving the right hemisphere and the left hemisphere that appear to be engaged in the process of recovery, although we can think about making specific focal modulations to that system in order to improve its efficiency. So this is a good opportunity to turn now to the other workhorse of our laboratory, which is transcranial direct current stimulation. I suspect that this team is also familiar with this technology, but just to give it the quick once over, tDCS involves the application of a very low amount of stimulation, low current. So what you're doing is you apply electrodes to the scalp. It's non-invasive. At least one of those electrodes must be an anode. At least one of those electrodes must be a cathode, because the electricity is going to run, between the two polarities of electrodes, right? And so, like I said, the current is very low. We're talking about 1-2 milliamps. And what happens is that this is insufficient to cause spontaneous depolarization of neurons. It's not like you turn it on and bam, you get instantaneous stimulation. What happens, we think, is that you take millions of neurons and you nudge them a little closer, a little farther away from their action potential firing threshold. So the net effect of which is that over time, you're effectively altering neuronal firing rates, which can, in the right context, have influences on cortical excitability and on behavior. We know that the technology it's extremely safe. In the entire history of the technology, no one has suffered a serious adverse effect. It's inexpensive, particularly relative to other stimulation technologies like TMS. It combines well with other therapies like physical therapy, speech language therapy. And like TMS, if you apply it multiple times, you can induce lasting changes in performance that we think happen through mechanisms of neuroplasticity, like long-term potentiation. Now, one potential downside of tDCS is that conventional stimulation has pretty low spatial resolution. So what I'm showing here is a finite element model of the distribution of current in a person receiving tDCS using a pretty commonly employed montage of electrodes. And so what you can see is you don't get just focal activity right under the pads. What you get is just a smear of activity that runs between the two electrodes. All right, the electricity just wants to get from point A to point B, and it does so in a pretty messy manner, at least using conventional stimulation. Well, that could be a downside if what you were trying to do is establish some very detailed and specific structure-function relationship, using this tool where it's important to stimulate one area, but definitely not another. However, if you are trying to apply stimulation to a broad bilateral network of areas that you think are engaged in compensation for lost abilities, for example, what we've just hypothesized is a bilateral network, a bilateral constellation of brain activities in persons with post-stroke aphasia, well, maybe this messy tool could be the right tool for the job. And so, and we started out. We brought individuals in. We actually subjected them to a optimal montage finding phase. We were pretty agnostic in early days about whether we should be applying the anode to one hemisphere, the cathode to the other hemisphere, the cathode to that one hemisphere, and the anode to the other hemisphere. So we went through an initial phase where we searched for what worked best for each person. But then we did a very similar study design to what we did with our individuals in our TMS study, where we randomized individuals to sham and real tDCS. We followed them up at 2 weeks and 2 months, and then everyone who got stimulation, or everyone who got sham stimulation, crossed over into our real phase. And you can see what our results here are down below. And this time it's a better graph, so you actually see the sham data too, and so you can see that individuals who received real tDCS have a significant improvement in performance. What I'm showing in the y-axis, by the way, is percent change in what is called the Western Aphasia Battery Aphasia Quotient. So that is a measure of overall aphasia severity. And so, these are reasonably, these are pretty substantive improvements with respect to an overall measure of aphasia severity in persons with chronic aphasia who don't typically have these kinds of changes in aphasia severity at the chronic phase. All right, so again, time has passed, and we certainly aren't the only people who've been engaged in this kind of work. As you can see in this illustration of where people have stimulated, where red circles represent anodal stimulation, black circles represent cathodal stimulation. It's been a bit of a hodgepodge of where people stimulate and with which polarity of electrode, which I think, again, speaks to the idea that the technology has a pretty low spatial resolution. So they're probably just covering a large amount of area with stimulation, in some ways irrespective of where they're placing electrodes. But what we can demonstrate is that across multiple studies that have employed this approach, again, tDCS is favored compared to sham in a meta-analysis we did several years ago. I would be remiss if I did not mention what is the largest, as far as I know, study involving the use of tDCS in patients with post-stroke aphasia. This was done by Julius Friedrichsen in South Carolina a few years ago now, and in 74 individuals, which, you know, for a tDCS study or neuromodulation study is pretty good, demonstrated that anodal stimulation. Well, first they did an analysis and demonstrated that it wasn't futile. It was a non-futility analysis, that anodal tDCS was not futile to administer compared to sham, and then subsequently demonstrated statistically that it was that it showed superior benefit. Our group has also gotten interested in the use of tDCS in patients with neurodegenerative aphasia syndromes. And I don't think time permits me to go through a prolonged introduction to the different neurodegenerative syndromes, also termed primary progressive aphasias or PPAs. So suffice it to say, there are currently 3 identified syndromes. One of them, termed non-fluent agrammatic variant PPA, has exactly those symptoms. So lack of fluency and agrammatism is associated with more frontal lobe atrophy, as illustrated here in the red. There is a semantic variant that, as the name implies, involves deficits of semantic processing and involves a lot of temporal lobe atrophy, as illustrated by the green in this figure. And then there's a so-called logopenic variant characterized by word finding pauses, prominent problems with repetition, and it's thought to involve deficits of verbal short-term memory, and has a more posterior pattern of atrophy, often pathologically is associated with the same pathological substrates as Alzheimer's disease. It's represented here in the purple where the atrophy is. So, you know, we, because these syndromes are a little bit less common than post-stroke aphasia, which is very common, you know, we took a beggars can't be choosers approach in terms of picking our initial montages to stimulate these individuals, and tried to pick a montage that would hit the entire left hemisphere perisylvian language relevant regions, right? And so you can see a finite element model of the distribution of current. You can see we hit much of the left hemisphere in some of our early work. And so we started with an open label study in which we stimulated individuals for 10 days, followed them 6 weeks and 12 weeks out. And we were able to demonstrate that, again, in our open label work, that we had improvement in speech production, repetition, grammatical comprehension, semantic processing. We put it all together into a composite measure, demonstrated to demonstrate a global improvement. Since then, we've introduced a control arm, and demonstrated that individuals continue to have improvement in a variety of measures of language performance. For example, this one, which is a change in baseline in category fluency. We also found, once we started digging a little bit further, that it tended to be the case that individuals who started with worse baseline severity appeared to have more improvement or be more responsive to stimulation than individuals who started at a relatively high baseline. And, you know, I think for those of you who are statisticians in the audience, you may say, well, okay, that might be just regression to the mean. And, you know, I'd be inclined to say that might be the case. But what I would also say is that it is very uncommon in interventions in aphasia that your most severely affected individuals show the best benefits. In fact, it's often the case that those patients show the weakest benefits. So the fact that we have an intervention where individuals who are pretty severely affected are the ones that seem to benefit was very encouraging for us. Again, I'd be remiss to say that if to portray this as if we're the only group doing this. Karina Tapkini at Johns Hopkins, working with R.G. Hillis and others, have been doing fantastic work in persons with primary progressive aphasia. So this is from their relatively large and recent study demonstrating in a cohort of 36 individuals that that tDCS can be applied beneficially to persons with, well, in their study, they found it to be beneficial in non-fluent agrammatic aphasia and logopenic variant aphasia, not so much in the persons with the semantic variant. So that's sort of a whirlwind tour of what we have been interested in, what we have done. In the remaining time, I want to talk a little bit about what's next for us. And the way I want to do that is to divide things up into insights we've achieved, knowledge gaps, and next steps. So we have numerous encouraging proof of concept studies. I hope I've demonstrated that, but I think it's insufficient data to justify widespread use of these technologies yet. And so the next steps for us are larger randomized controlled trials. I think that interhemispheric inhibition has worked as a useful framework, but these models that guide neuromodulation are oversimplifications at best. So I think we need novel tools and models to characterize language system plasticity. Specific approaches like 1 Hz repetitive TMS to the pars triangularis seem effective, but we don't know if other sites and parameters are useful. And so we need novel mechanistically informed sites and stimulation parameters. And then finally, individual responses to neuromodulation vary widely. So there's a lack of evidence regarding the factors that predict response to neuromodulation. So for that, we need to explore predictive patient features and intermediate markers of plasticity. So in the last few minutes, I want to talk a little bit about what we're doing in those regards. So as far as larger and more trials, we're engaged in several trials now, including a phase 2 clinical trial in which we're applying TMS to individuals with chronic post-stroke aphasia using the same methodology that we employed in our early TMS studies. So 1 Hz stimulation to the pars triangularis on the right. We're also running 2 studies, one Department of Defense funded or Department of the Army funded, and the other funded by the NIH and NIA, looking at the use of tDCS and high definition tDCS in persons with primary progressive aphasia. As far as novel targets and parameters go, I'm not showing you our data. This is some from last year, or well, now I guess 2 years ago, which I found encouraging. It's looking at the use of excitatory stimulation over Wernicke's area in patients with chronic aphasia, demonstrating that in those individuals, you can improve measures of comprehension, at least temporarily, after applying stimulation in this fairly different way from how it's been applied in many studies, the inhibitory stimulation that's been applied in many TMS studies of patients with aphasia. Thinking about the factors that predict response to stimulation, I mentioned already a little bit about the importance of baseline impairments, that we found that baseline severity was a predictor of response in tDCS. Incidentally, we also found that to be the case in our TMS studies as well. But in addition, we've also gotten interested in what categories of deficits patients have, and if those categories of deficits predict improvement. And in particular, we've looked at whether or not a patient's phonological naming errors versus semantic naming errors have any purchase in predicting how they're going to respond. And to make a long story short, it seems to be the case that their phonologic errors are most predictive of how they're going to respond to TMS, at least in a study where we brought them in and applied TMS transiently. Again, inhibitory stimulation of the right pars triangularis. And as I mentioned, we've now run several studies showing that baseline severity seems to be a predictor of neuromodulation response. We're also interested in factors related to cortical plasticity itself, and whether differences in cortical plasticity between subjects, between patients, predicts their response to neuromodulation, and whether it predicts their response to any kind of intervention for aphasia or their recovery from aphasia at all. And so we focused on cortical physiology measures of plasticity, and this requires a little bit of a detour, a bit of explanation. So We can stimulate over the motor cortex. I think I've talked about that a little bit before. And you can use motor evoked potentials, motor stimulation, as a kind of index of how excitable your brain is, right? And the amount of stimulation it takes to stimulate over a site and to elicit a motor response is an index of how excitable the cortex might be. Well, we can use a different kind of TMS, theta burst stimulation, in this case, what's called continuous theta burst stimulation. It's robust inhibitory stimulation, to transiently manipulate that excitability, in this case, suppress it, and then use the motor evoked potentials over time to see how suppressed that activity is and how long it takes to come back. And in our lab, we've been using that as a kind of index of plasticity. In order, let me make a metaphor here to make that a little clearer. In our mind, the longer it takes for the brain to kind of bounce back after manipulation is a kind of index of how plastic it is. The metaphor I like to use is that of memory foam, right? You sort of press down on the memory foam, and how long it takes for the memory foam to get back into place is sort of an index of how sort of malleable that foam is. So using that approach, we also have gotten interested in genetic differences that predict plasticity, and whether those differences predict response to neuromodulation, and also whether they predict the overall recovery for individuals with aphasia, and if those interact. And so what we've been able to demonstrate in recent months, is that yes, if we can apply this protocol to suppress cortical excitability and use it as a kind of measure of plasticity, and we can look at individuals who vary in terms of their genotype for a very specific gene, the brain-derived neurotrophic factor gene, which is it's a protein that is very involved in various aspects of neuroplasticity. It turns out about a quarter of the population has a genotype that codes for a less robustly active gene across a variety of different measures, right? And so what we can demonstrate is that, in fact, individuals who have that rarer genotype, that they have a markedly different response to this TMS suppression of cortical activity, right? In other words, they have a less plastic response to suppression of TMS activity, which seems to correspond with the fact that they demonstrate less plasticity in a number of different other measures, including measures of behavior. Well, it turns out that more than that, this has some relevance to individuals with aphasia. So these data are collected in individuals with chronic stroke and aphasia. And what we demonstrate is that in addition to having big differences in their motor physiology and motor response, individuals with this less common, this VAL-MET genotype, also, if you factor that into a model of their chronic recovery, like their actual recovery from aphasia, you find that individuals who are VAL-66 MET, this less common genotype, have poorer recovery from aphasia overall. Moreover, if you develop a model in which you use this motor response, right, this TMS response as a variable, think of it as a measure of plasticity, we throw it into our model. Well, in the individuals who are VAL-66 MET, it seems to be pretty informative. In other words, it itself then becomes a predictor of, to some extent, how these individuals are going to recover from their aphasia over time. So at least in some patients, you can use a TMS marker of cortical plasticity as an overall predictor, or a contribution to an overall prediction of how individuals will recover from their aphasia. And so again, our interest moving forward is in using these kinds of markers to predict who's going to recover from aphasia and how they're going to respond to neuromodulation interventions. One last point I'll make, the sort of future direction for us, is that we're looking at how anatomical language network properties predict response to TMS. And so what we're doing here is we're looking at the not the functional connectivity, but the anatomical connectivity, the networks engendered by white matter tracts, under the basic idea that cognitive localization in the brain is a function of local and global connectivity. And so, we should be able to look at different nodes, different sites within the language network, and make inferences about what the what those areas do based on their connectivity. And so this is a very simple cartoon illustrating the idea that a node that's organized like this with respect to its connectivity ought to have a very different job, do a very different thing than a node that has these kinds of connections, right? This one integrates and separates big modules. This one is sort of the hub of its own module, whereas this one seems to have a very specific and isolated effect. It sort of manipulates the activation or engagement of this other node, and that's basically it, right? And so our idea is to, sorry, I should put those arrows in, is to employ something called network control theory, a set of ideas borrowed from neuroengineering, which allows for inferences about the operational utility of brain centers based on those anatomic connections. And so that's what we've been doing more recently. We start our work with individuals who are healthy, and what we do is we develop individual networks of connectivity. So we're looking at individual anatomic connectivity maps of individuals, and we identify different network properties that we look at and that we can identify on an individual basis at different sites in the brain. So what I mean by that is, let's take this property called boundary controllability, which I alluded to without naming a few minutes ago. It's that property of being able to separate or integrate large modules. So this, for example, is a node that has high boundary controllability. Well, we can make individual maps both of different regions of the brain, but also across different individuals to show how they vary at different sites with respect to their boundary controllability. So this would be one person's boundary controllability in say Broca's area. This would be another person's boundary controllability in Broca's area. Contrast that with something called modal controllability, which I also alluded to a couple minutes ago, the ability to manipulate networks into highly specific states. So for example, this node, which only does one thing, manipulates that node, so a very specific state, that would have a lot of modal controllability. We can do the same thing, so form individual maps of those properties at different sites in the brain. And one of our hypotheses is that these properties are relevant for different kinds of language tasks. So for instance, in a recent paper, my main partner in this, John Medaglia, reported that individuals differ, or hypothesized that different variables would be necessary for open-ended tasks like sentence completion. For example, if you completed this sentence here, right, there are a lot of different options. And so you need this kind of ability to integrate and segregate across different semantic networks in order to choose appropriate options, as opposed to closed-ended questions where there's really just one answer, right? Read this number. There's only one way to read that. You want to manipulate your network in a very specific way to a very specific state. And what we were able to demonstrate was, in fact, in the interest of time, I'll say this briefly, that that boundary control for individuals was predictive of in Broca's area in particular, in healthy individuals, was predictive and relevant for performing open tasks. In other words, if you had high boundary control in your inferior frontal gyrus, then applying inhibitory stimulation to that site for you, if you were a healthy individual, would manipulate your performance of open tasks. Whereas the same was true that the modal control was important in Broca's area for the purpose of performing closed tasks. That stimulation seemed to make a difference for those individuals, for individuals with high modal controllability on those tasks when you stimulated Broca's area. So the bottom line is that individual network anatomy seems to be something that we can now start to use to predict response to TMS. Right? And so our big hope is that we'll refine this further as we move forward and be able to use these kinds of anatomic network properties in order to identify why regions in the right hemisphere seem to get activated in individuals with post-stroke aphasia, and maybe start to make more intelligent choices as to how we pick which areas to stimulate to manipulate which behavioral properties. All right, so to conclude, I hope I've convinced you that aphasia engages a bihemispheric post-stroke language network, that focal manipulation of the right inferior frontal gyrus with TMS enhances language performance, that diffuse direct current stimulation may facilitate recovery in both post-stroke aphasia and in primary progressive aphasia, and looking towards the future, that bigger studies, novel imaging tools, and better predictors of treatment response are on the horizon for neuromodulation in aphasia. With that, I'd like to thank you. Obviously, this work comes from a big team and a long history of collaboration. I'd like to thank all those who've been engaged in this in over the course of many years, and in particular the current team that's listed here. And with that, I'm happy to take any questions.
Thank you very much. That was fantastic. Are there any questions? So I think there's some questions in the chat. I'll read it for those who don't have access. From Rachel Harrington, I've always been interested from that Jove paper that naming got worse after suppression of right POP, posterior pars opercularis, I apologize. Would you ever consider exciting that area?
Yeah, so that's an interesting question. And there's I think
somehow you're
data.
muted.
Am I
No,
still muted? Can you hear me?
Maybe it's me, I apologize.
I don't have my mute on, so I think I can be heard. Okay, thank you, Rachel. So, there's actually, I think, mixed data and even mixed evidence from our group with respect to and our original collaborators. So, we did a lot of this work with Alvaro Pasqualeone and Margaret Nazer when she was at BU, and it seemed to be the case that stimulating the pars opercularis may actually have a different effect, as you intimate in your question. But it didn't seem like it was always the case. It didn't have the same robustness of effect as and consistency that we had seen in the pars triangularis in individuals. But certainly, suppressing that region could have been a possible approach. Now, one challenge, let me say, in that is that for many individuals, we found that the pars triangularis was actually, this is wading into the weeds just a little bit, was bifurcated in a way that doesn't show up in a lot of the textbooks, such that the region where we ended up stimulating and having a lot of effect was sort of a more posterior region of that pars triangularis, which would be like literally the next door neighbor. I mean, very, very close to the pars opercularis. So, it gets a little, it could be a challenge, you might imagine methodologically. While I describe TMS as being a high resolution technology, we are talking about things that are very immediate next door neighbors. And so, we thought that we would at least start with the approach of inhibitory stimulation of the pars triangularis. But you are correct that there may be, for some individuals, an effect of applying excitatory stimulation to the pars opercularis. Again, we need better rules. I mean, I think part of what I was trying to say at the end of the talk is we need better rules for determining where we ought to be stimulating, individuals to sort of make those kinds of decisions.
Great, thank you. I apologize, the audio issue was just me. Next, Eileen, would you like to ask your question?
Sure. Roy, thank you for this really fascinating talk. I was particularly interested in one thing you kind of passed by a little bit. In your study talking about using tDCS to study people with primary progressive aphasia, you mentioned a stage where you determine the optimal montage. I wonder if you could say a little bit about how you did that.
Actually, those are two different studies. So maybe I did blow by this too quickly. If you're, so we did the site finding in our tDCS for post-stroke aphasia. Okay. And so we did not do site finding for tDCS for primary progressive aphasia. There, what we actually did, I mean, I would view it almost as the opposite of site finding, because at least in our early work, we chose a montage for everyone, but we tried to ensure with finite element modeling that montage would hit basically the entire perisylvian circuit, that we would get current going through the inferior frontal gyrus, the middle frontal gyrus, superior temporal gyrus, to some extent the anterior temporal pole. And the reason for that was, well, primary progressive aphasia, while it is far more common than people think, pales in comparison in its commonness to post-stroke aphasia, right? So we were dealing with we weren't powered to pick and choose and split stimulation approaches with our different patients, and coming in with the different subtypes, and so we applied the same montage to all of them, and basically tried to pick a one that would hit all the critical sites for all the individuals.
Great, thank you.
All right, next, John Greenfield's question in the chat box. How long do stimulation-induced language improvements last after DC or TMS stimulation? Also, how age-dependent are the responses? We know that young people recover from stroke far better than elderly patients, maybe due to greater intrinsic plasticity of response.
So I'm just going to go ahead and answer the second question by saying I don't know, because I don't think that we have, and I don't, to my knowledge, if someone wants to come on the chat and correct me, please do, but I don't think there has been a good study stratifying by age, right? And so you could certainly generate intuitions about whether or not individuals with who are younger would be more responsive to TMS or to tDCS or any form of neuromodulation than individuals who are older. For instance, you can imagine that the same, if you think of age as a plasticity factor, right? We can demonstrate other plasticity factors like genotype, have pretty dramatic effect on your response to brain stimulation. So maybe as a plasticity factor, age is too, but that's an empirical question that I don't think has been sorted out in persons with aphasia. To answer your first question, it depends on how long you stimulate or how often you stimulate. So, when we were doing our site finding phases, we were inducing changes in performance that were lasting 20, 30 minutes. Right, but that was just for the purposes of trying to find a place to stimulate. And then we brought individuals in for basically 2 weeks. I underemphasized that aspect of the methodology. Two weeks of daily stimulation at the same site. And what we were finding is that individuals were coming in. I don't know if you recall the graphs, but basically the further out we followed them, the larger effects that we saw, and we're not the only people who actually report this. And so we don't know if those effects wear off at some time for individuals, say with post-stroke aphasia for whom we've made changes. One hypothesis, one model is that what we do is create changes in patterns of cortical activity that may be on some level self-reifying. So if that's the case, then you wouldn't expect that what you would see is a kind of medicine-like effect where it sort of wears off after a period of time. You would expect a kind of neural network-like effect where, once the system is kind of changed and now it sort of that change reinforces itself, that you might expect to see persistence or even larger effects over time. So while the answer to the second question is also I don't know, it's I think for a much more interesting reason that it may be the case that neuromodulation effects work in very different ways than just sort of on-off or wearing off effects like medications would.
Great, thank you. Are there any other questions? I have a lot, but maybe I can just ask at least one of them. If there's no other questions, but please do raise your hand or just unmute yourself if you have questions. All right, I'm gonna ask one question. If you recall towards the end of your talk, you were talking about boundary control and modal control kind of conditions. And I'm very curious, so a couple of things related to it. One is, why do you think, and maybe you've said this and I wasn't paying attention, but why do you think there's kind of differential effects on open tasks versus closed tasks? And also just one clarifying question, are these regions defined, you said it was defined based on individual connectomic sort of maps, and you identify, so can the that kind of node move around, or is it always in that inferior frontal or whatever region?
Yeah, so those are great questions. So the answer to the first question is that, you know, we started with an intuition about what kind of network properties are the kind of network properties that allow for you to very flexibly search across different sort of categories and domains if you're trying to answer a question. And, you know, thinking about the different network properties in network control theory, it seemed that one that allowed you to quickly and efficiently sort of join these networks or separate them would be one that would be particularly useful, or at least it had a kind of, to us, an intuition that would be the useful one for those kinds of tasks, right? Whereas by the same token, we thought that, and again, a lot of this was driven by an intuition, the intuition that you have a specific answer, like there's only one answer to this question and you have to get to that answer, that there might be some, when you're talking about performing a language task or a language control task, that there might be some particular utility for the property of getting the network into a very specific state, right? And so that was the intuition that drove that hypothesis. Now, what I showed you, the best nodes to represent those properties may certainly differ across individuals. So I realized, because you know, I was going a little bit faster at the end in the interest of time, I may have skipped over this feature. That's not what we were doing in this initial set of experiments. What we're doing in this initial set of experiments is picking the same site in all individuals that we knew as a language-related site, right? Broca's area, different individuals, for different individuals, they may vary in that network property at that site, right? And so because we're applying TMS to that site across all the individuals. Now you can imagine a future study, which, and I think it's actually embedded in your question to some extent, where we're picking the strongest sites irrespective of where they appear in the brain, right? Or where they appear in the language network. And that is a future direction that we're very interested in, but that's not the approach we took in this first set of papers.
Got it. Great. Thank you very much. I think there's one more question from Eileen. Would you like to go? And you'll be the last person asking questions.
Sure, great, thanks. I guess my question is kind of on the opposite end of the spectrum. I'm just going back to your tDCS work with the people with primal progressive aphasia. Given that there can be sort of non-linguistic problems, like, you know, inappropriate behavior and that type of thing, I wonder if you guys noticed or looked at all about any non-linguistic benefits to the stimulation?
So we did not in our initial work, you know, and maybe that's our fault for being over-focused on the language system. But, you know, we now are, so with our current R01 and DOD work, we have the advantage that we are recruiting patients from Penn's FTD Center. And so these patients are deeply phenotyped by virtue of their participation in the center, and have routine behavioral batteries as they return for assessment on an annual and sometimes more basis. And so moving forward, we're going to be able to see whether or not we see any change in signal in measures other than language in these individuals. And you're right, you know, these are messy constructs. It's not as if patients with PPAs only and specifically have language problems, you know, because the pathology is also representative of other very closely linked diseases. So it will be interesting to us to see if we move the needle on any other symptoms. Great question.
Very cool. Thank you. I look forward to learning about that.
Sure.